So I'd like to thank the organizers for the invitation to present at the European Society of Human Genetics, and specifically a topic that's really close to my heart, which is precision medicine in underserved populations. So today I'm going to talk about and summarize some interesting findings about improving precision medicine for breast cancer in Africa. And I thought I'd start with my motivation for being in this field. And so I grew up in New York City. My family comes from Puerto Rico, and so I have mixed ancestry. And it's been my passion to conduct studies in diverse populations reflecting our communities, to provide new information about the causes of cancer and really allow us to develop the relevant and culturally appropriate strategies to address disparities. And I don't think, many times this has been focused on just access to care and health systems. And of course, this is absolutely important. But also, I think it's important to consider and do molecular studies in various different populations. And so you can see here, my genetics is quite all over the place. And the blue is representing my European ancestry, while the pinkish purple is representing my African ancestry, and the orangey yellow is reflecting my indigenous roots. And I think, it's important for us to be having more population studies that reflect our communities from all over the world. And although this, talk was focused, the task at hand was said, precision medicine in African populations and breast cancer. As a, epidemiologist, I also think it's very important to think about precision prevention, because if we can also understand how we can prevent disease, I think that's going to be the most effective approach to not only reducing incidence, but also hopefully, minimizing the need for more treatment. And that strategy, of course, is not limited to Africa, although, where resources are limited in terms of health systems, prevention should be the primary focus. But obviously people will still get cancer, and so precision medicine is going to be a key aspect as well. And so, for example, precision prevention, entails, when you're looking at the general population, what are various strategies that we could do to reduce incidence of disease as well? Smoking obviously is a key area. Reducing obesity is now obviously one of the key aspects that we're trying to do. HPV vaccination obviously can prevent cervical cancer and many other cancers, also in men. When we're looking at the individual level, obviously we want to look at high risk, and identify patients and people who would be at high risk. So, how can we minimize exposure? How can we, identify, cancers early so that we don't have to treat them, and so that treatments, are not as severe. And then, we keep going up and looking at carriers of high-risk mutations, for example, BRCA1, BRCA2 mutation status. We've actually changed, prevention and improved outcomes for such patients, especially in the Ashkenazi Jewish setting, and, have developed new strategies to make sure that they can have long, healthy lives. And then, of course, precision medicine is once you have the cancer, how can we target it better to improve survival? So I'm taking a little bit of liberty in this talk and extending not just about Africa and precision medicine, but also precision prevention. And why are we looking at this? Well, African women have some of the highest mortality rates in the world when it comes to breast cancer. And this is data based from the International Agency of Research in Cancer. And you can see within the belt in sub-Saharan Africa in particular, there are some of the highest rates at over 18 deaths per 100,000. Now, breast cancer, like many diseases, is extremely heterogeneous. And many years ago, one of the key things, and it's not just heterogeneous, but it's also the model of precision medicine. And I think it could also be a model for precision prevention. Um, so back in 1896, there was the observation by Sir George Benson that breast cancer would regress after oophorectomy, and this was a very small sample of patients back then. But it became one of the first observations that suggested that perhaps hormones, which of course the ovaries produce, are an important factor in terms of the etiology. Fast forward to the 50s, Elwood Jensen discovers estrogen and discovers the receptors that bind to estrogen, and actually shows that estrogen-rich breast cancers, responded better to endocrine ablation. So this really accelerated the idea that there is different types of cancers, and how they, progress and respond to hormones actually differs. Again, later on, tamoxifen, of course, became a very common breast cancer treatment. And, the seminal work in the Lancet and the early breast cancer trial showed that, within an RCT, that tamoxifen actually prevented deaths from breast cancer. So it's been long established that estrogen is a very important factor and distinguisher of different outcomes for breast cancer. So obviously, breast cancer is heterogeneous. ER is one of the key markers, to distinguish them. But of course, there's many, many other markers, and I'll discuss a little bit of that later on in the talk. But also, access to care and health settings are also important in terms of distinguishing, what kinds of cancers might be diagnosed. So, for example, in the UK and in Scotland in particular, we have over a quarter of breast cancers diagnosed through mammography screening. We have the NHS, so we have organized and universal healthcare. And participation in screening is quite high at over 70%. And it's been, observed that women of African ancestry are more likely to be diagnosed with early onset aggressive ER-negative breast cancers. And this has been seen both in the UK as well as the US. And they have higher mortality compared to whites. And yet we have very, very little data on these populations. They only represent about 8% of cases in TCGA. And, although they're oversampled within the breast cancer data sets, it's still pretty poorly, addressed. And just to illustrate, some of the challenges we have. So to try and look at more recent data, I did a quick, search of the literature. There's not a lot of data out there, although it's increasing, and I suspect it's probably in better shape than it was probably 20 or 30 years ago. Limiting it to samples of 100 or more. I mean, there's a lot of small studies of less than 100, but very few, and I counted about 15 since 2010. That I've looked at ER status. And you can see in this map that the distribution and proportion of hormone receptor positive breast cancers ranges all the way from 36% in Rwanda to 71%. And this is still only 5,000 cases when you add it all up. And it's still, there's lots of issues, and we really need to do a better job of having good, accurate data. And I think a real key issue is also having similar sample types, especially biopsy samples, which I'll discuss a little bit more in a minute. Another thing that's important to recognize is that, breast cancer incidence is going to be influenced by mammography screening. So this is a paper we recently published using Scottish data from 1997 to 2016. And you can see that mammography screening, which is, in the UK, we have mammography screening every 3 years from age 50 to around 70. It's slightly older, 72, I think now. And you can see that since 1997, the rates of breast cancer have increased amongst the screened population. But when you look at this more closely with those that are screen detected or not screen detected, you can see that basically screen detected tumors amongst the 50 to 70-year-olds are really being driven um, are basically ER positive breast cancers. We haven't seen much change at all for ER negative breast cancers. So this is really important, I think, in terms of understanding, depending on the types of tumors that are diagnosed in the population, we might need to think of different ways to try and, detect them early. And we might need to look at different strategies. So now I'm going to talk about a study that I designed with Louise Brinton back when I was at the National Cancer Institute, and currently the PI is Monse Garcia Closas. But this was a collaboration between the National Cancer Institute in the U.S., the University of Ghana, Kolebu Teaching Hospital, Peace and Love Hospital, and Komfanochi Teaching Hospital in Ghana. And the idea was to try and understand risk factors for breast cancer, but also we're looking at also to look at survival as well. So this was a population-based case control study, and we recruited over 2,000 controls and about an equal number of cases. So we had about 2,000 cases, 2,000 controls. About half of the cases were invasive, and the reason that was because we targeted women who were suspected of breast cancer. And many of these women then had core biopsies, which we standardized across all the hospitals, which was important in order to be able to make sure we could get good quality biopsy material for hormone receptor status and molecular subtyping. So because we targeted women at the time of suspected breast cancer, about half of these women wound up not being invasive breast cancers, but rather non-malignant. And this was done in 2 cities, Accra and Kumasi. And we had one population control identified for each case. So we had very detailed interviews, anthropometric measures, collection of blood, saliva, fecal samples, and biopsy tissue. And we standardized also the procedures across all the different hospitals, including, the study staff in terms of questionnaire, very intensive training. I remember that week very well. And to make sure things were standardized across the 3 different hospital sites. But as I mentioned, one of the issues, as you saw in the previous slide, is that there's huge variation in terms of the proportion of ER-positive breast cancers that are reported in the literature in Africa. And in order to make sure we had the best quality, we focused only on true cut biopsy material because we know that it's small and it can get fixed quickly, allowing it to be the best material for immunohistochemistry. And one of the good things about this there's a picture here of Lisa Newman, colleague of mine now at Weill Cornell, who's an exceptional surgeon, who actually trained our collaborator Beatrice Wayafi and their staff in terms of doing true cut biopsies, and that has become now a mainstay of their treatment diagnostic procedures for their patients. And so even these little things, I think, have made a huge difference in terms of improving patient lives and hopefully precision medicine, just getting ER status correct so that the patients who can actually benefit from the treatment will actually get it and get it done well. So as I mentioned, this was a population-based case control study, which is really important because this is going to allow us to estimate rates of not only breast cancer, but hopefully also the attributable risk for different factors, as well as understand mortality when we get to that. And so the way we were able to do this was we randomly selected enumeration areas within different districts where the cases were expected. and had household censuses of those enumeration areas, and then identified women, of appropriate ages that were randomly selected to be invited to the study. And I would say we had over 90%, response rates for cases and controls. So this study is really high quality. So some of the things that we're trying to address with the Ghana Breast Health Study, and that I'll just highlight here now, is reasons for delay in seeking health care and use of non-traditional care, body fat distribution, hair relaxers and skin lighteners, and genetic markers. So this is a picture of an herbal clinic ad, and this is not exclusive to sub-Saharan Africa, but many low and middle income countries have a lot of herbal and traditional healer clinics. And I think, it is really important to consider these different types of aspects of potential care. And there might be some, benefits to some herbal remedies. But, I think working together with the hospitals and the other medical professionals, I think would be really important. And this we were able to show, in terms of, looking at delays to diagnosis. So in the Ghana Breast Health Study, over half of the patients are under the age of 55, so close to 64%. And about half of them, more than half of them, have tumors diagnosed over 5 centimeters. This is not something you would see in the UK or US, really. So when we compared the small tumors, those less than 5 centimeters, to those greater than 5 centimeters, we use this as a proxy of delays to diagnosis. So basically using tumor size as a proxy for delays. And so when we looked at that, we were able to identify that education was a key factor. So those that had only primary school or less, compared to those that had secondary or university or technical school, were over twofold more likely to have larger tumors. And time, the time between symptoms and care, so we didn't see much difference between 6 or 12 months compared to less than 2 months. But definitely, the delays, if they waited more than 6 months, that this was definitely associated with the larger tumors. And who they sought from care from first was actually a big factor associated with delays to diagnosis. So there are efforts to try and work together both with the traditional healers as well as the medical facilities where care and breast cancer care can actually be undertaken to hopefully bring patients forward more quickly so that the treatment and hopefully survival can be improved. Now, body size in breast cancer has been controversial, especially in European populations. And so, you can't just ask people what their BMI is in low resource settings. So in Ghana, what we did was similar to what Fumiola Padi's group had done in looking at pictograms of body size to get at what, potential levels of obesity. And what's interesting about this work is, and some of these data are published, but what was pretty clear is that body size is associated with risk for breast cancer, regardless of the type. So it seems to be increasing risk overall for ER positive, ER negative, for younger breast cancers, for older breast cancers. And so this is something for sure that could be targeted and hopefully improve and hopefully reduce the incidence and hopefully improve mortality outcomes for breast cancer patients in Africa. Some other unique, exposures that are probably only, seen in Africa, but also some other low middle income countries. There's a recent a Ghanaian survey that showed that about a quarter of the population actually skin bleach. Obviously, this is extremely sad that people need to feel like that they have to lighten their skin. But also hair relaxers is very, very common amongst women. And with both of these different types of products, it's thought that there might be some, chemicals that actually, might be hormonally related and also increase the risk for breast cancer. So we didn't find much evidence for skin lighteners, very, very limited, nothing significant. It was slightly elevated, especially for former versus never users. But for hair relaxers, we were able to see that ever versus never use was significantly associated, even when we adjusted for age, study site, education, parity, body size, and family history of breast cancer. And there seemed to be a dose. I'm not showing it here, but it was in the publication. What's interesting is I just did a quick analysis to see whether or not this association differed by ER status. And it does seem to differ in that the association seems to be primarily amongst ER positive breast cancers. Although you still see increased risk for ER negative breast cancers, the association is not as strong, and it was significantly heterogeneous. So this also, I think, is really important. I mean, these are modifiable factors that don't need to be used and might actually reduce risk, not only for patients and the population in Africa, but many different places. So we've also looked at parity in breastfeeding, and we've shown that, as I mentioned, in Ghana, similar to what we've seen in European populations, women who have multiple births actually have an inverse association with breast cancer. This has probably helped keep rates low for breast cancer in Africa, so we don't, that's a good thing. We see the increased risk for ER negative breast cancers. And I suspect what we will see over time, because there are changing reproductive patterns, that we'll probably see actually fewer ER negative breast cancers over time with changing reproductive factors. And so the challenge is going to be, how can we improve, precision medicine or prevention, and hopefully reduce other factors that are increasing, like obesity. So, as I mentioned in the beginning, we've seen that there is a increased incidence of ER negative breast cancers in African American populations, and we haven't really understood why. So we wanted to understand whether or not rates would be similar or different in Ghanaian women. And if we see a similar rates, then perhaps that suggests that there's something endemic about ER negative breast cancers. So in fact, we see that the rates of breast cancer for Ghanaians, as seen here in the red, are about 40 per 100,000, and it's similar in African Americans. And it actually is higher than it is for whites. ER positive breast cancers, on the other hand, not surprising, are lower in Ghanaians compared to African Americans as compared to whites. And I suspect, of course, this is going to be multifactorial, including, screening participation, risk factor distributions, but also, but especially, reproductive patterns are quite distinct, and that's probably, as I said earlier, probably keeping rates low. Lastly, just wanted to talk about pathogenic mutations. We have some data now that suggests that there is some higher prevalence of pathogenic variants. There's been a recent publication called the Bridges study, mostly European population, so that had over 50,000 breast cancers and 50,000 controls. And so, we see that we actually see a higher frequency of pathogenic protein truncating variants compared to European populations. And the frequency of pathogenic variants in cases is about 8%, which is actually higher than what we see in African Americans from a cohort from Julie Palmer. And so again, this does actually support that maybe there are certain pathogenic, mutations in West Africa in particular. And so we need more studies, I think, to actually, tease this out. Lastly, I just wanted to share some exciting work that I've been doing in collaboration with Has Borlak and Samuel Ahuno, a student from Ghana, but working with Bas in New York at Mount Sinai. And I think the future, is really exciting in terms of the potential for other new diagnostics. And of course, people are really excited about the potential of liquid biopsies and the use of cell-free DNA from blood to be able to diagnose cancer. So we have a paper that's just recently been accepted and should be in press very shortly, where we looked at copy number alterations using cell-free DNA from blood samples collected in Ghana. And I must say we were lucky that we were able to detect cell-free DNA because we collected samples and we processed them quite quickly, although we didn't use any special tubes. And so this allowed us to actually be able to detect it. And you can see here that, within a sample of 15 cases, we actually saw quite a bit of circulating tumor DNA, more so than what we usually see in European populations. And we also saw that, in fact, the triple negative breast cancers had some of the highest levels of circulating tumor DNA medicine. And so, I hope you could take away from this this seminar, that the distribution of risk factors differ across African populations, but so do the subtypes. And further studies are really needed in diverse populations to determine factors associated with risks that could be targeted for policy and prevention to reduce the incidence. But also we need new prospective studies with detailed tumor pathology data and treatments to inform how mortality outcomes could be improved. And I just leave you with this distribution to show, how different the types of breast cancer are, from Scotland to Ghana to Kenya to South Africa. And we have not really done a good job to address what these factors could be in various different populations to improve patient health and also hopefully prevent the incidence of disease. So I'd like to thank all my collaborators from across the world, but more importantly, I want to thank the patients who so kindly contributed their samples and their time to make these data possible. Thank you.